Yeah. Wait, there's somebody else on there. Okay. Oh, April. If you get like financial aid, you can use that. Um, yeah, but you need to start saving money,
This one.
right? Okay.
Thank you.
Bye,
You want me to close
Raquel.
this?
Yes, please. Okay, hold on. Hi, April. Let's see. I'm trying to get in here. Let's see if you can hear me. My computer is telling me I need to turn up the volume. Looks okay. All right, guys. So, April, can you hear me? Just give me a something so I know that the audio is working.
Yes, I can hear you.
Okay, great. So what I'm gonna do today is I'm just gonna open up where we are in the course. And we did one of the Swift River case studies in class on Monday. That was about a patient with TB. So I feel like that was a really good review. And yeah, so let me just share my screen. Oh. And we'll just kind of talk through this. Okay, so module 3 is this big, has these big topics in it, the epidemiology, the evidence-based practice, and then prevention and control of diseases, which is a lot of communicable diseases stuff. You guys have your communicable disease discussion board coming up due pretty soon. I know a few people have already made their posts, and one of the students in the face-to-face class reached out to me to say that there was an issue with responding to other people's posts. So I checked and the settings were wrong, but I have now fixed that. Okay, so everybody should be able to, I mean, if I fixed it right. So if you're having trouble posting to somebody else's post, let me know and we'll try to figure it out. You guys, I posted down here for you guys these clinical judgment case studies that go with each of the chapters. And then I have the PowerPoint links. When I was reviewing the quiz for next week, I was like, yeah, I just talked about this stuff in the PowerPoints. So I would encourage you guys to give a listen to those. Make sure you feel comfortable without the material there. The blueprint has been posted. So those are all here. In class activities for this module, we have a video. It's a short, I think it's like 5 minutes, video about incidence and prevalence or prevalence. And it uses the bathtub model of incidence and prevalence, which I find is very helpful in understanding the difference of those. So I don't know, April, do you want me to show it now, or do you guys want to you'll come in and watch it later? What do you think?
Now's good.
Okay. Well, we'll see if this works, okay? Through the Zoom.
When describing the distribution of a disease within a population,
Okay, I'm gonna pause her to make sure. Can you hear her going?
Yeah, I can hear her.
Okay, awesome. So I'm gonna let
are
her.
used. Morbidity, the frequency of a disease, and mortality, deaths as a result of a disease.
Oh, there you are.
These can be assessed using two different measures of disease frequency, incidence and prevalence. Incidence is the rate at which people get the disease, the number of new cases. Prevalence is burden of disease, the proportion of people in a population with the disease. Which of these indicators is used depends on what you want to know about the distribution of a disease and the actual disease you are investigating. The difference between incidence and prevalence can be explained by using an analogy of a bathtub. The bathtub itself represents the whole of the population being investigated. This could be a country or a specific region or area. The water in the bathtub represents the number of people within the population who have the disease. This is the prevalence of the disease. The water coming from the tap into the bath represents the incidence of the disease, the number of new cases. The water level in the bath increases, adding to the prevalence or burden of the disease within the population as a whole. Those no longer with the disease, either due to death or cure, are represented by water leaving the bathtub from the drain. An increase in the incidence of a disease may increase the prevalence of the disease, but this also depends on the rate at which people are being cured or are dying from the disease. Let's look at an example. Cancer is measured using incidence rather than prevalence. This is because cancer is often a disease of relatively short duration. Even with advances in treatment, a lot of people with cancer will die shortly after diagnosis, or may even be diagnosed after death. If we return to the bathtub analogy, in cancer, water enters from the tap and quickly leaves the bath via the drain. With the water quickly leaving the bathtub, it would not be useful to measure the water in the bathtub at any given time, the prevalence. It would be much more useful to measure the water entering the bathtub from the tap by measuring the number of new cases, the incidence. A contrasting example is COPD, chronic obstructive pulmonary disease. Prevalence is used as COPD is usually a condition with a long duration. Most people are diagnosed and live with the condition for a number of years. The number of people living with COPD, the prevalence as represented by the water in the bathtub, is a more useful measure than just the number of new cases.
Okay, I'm gonna pause there so we can look at this for just a second. And let's think about, like, if you're a school nurse. So we might want to look at our incidence of flu, right? Because that's gonna spike quickly, and we want to think about implementing measures. Hi, Lindsay. We're just going over incidence and prevalence to help decrease that rising incidence. But people are going to get well from flu relatively quickly, right? So then that'll fall again. But we might measure the prevalence of problems that are going to be around for a longer time. And so maybe our prevalence of obese children or our prevalence of kiddos with a learning disability they're gonna stay in the population and having an idea of what is the rate, like every 10 out of every 100 kids has a learning disability. I don't know if that's right. It might be higher. But that prevalence is really important. And then we could compare like this school and the prevalence there of one of these problems that hangs around for a long time with a school somewhere else that has more or less resources. Let's see what else she has to say.
With long-term or chronic conditions such as COPD, we are more interested in the water in the bathtub, as there is a plug keeping most of the water from going down the drain. The water coming through the tap is only giving us part of the picture.
Okay. So have we watched the upstream, downstream one? Okay, let's look at this too. So in this module, there are a number of kind of models, concepts that can be applied in lots of different scenarios. So the incidence prevalence one is definitely one. And then this upstream, downstream is another important concept.
Right, so welcome back to Social Determinants of Health. Before we get started, I want you to take a look at this picture and think about what you see here. You've got a river, we've got kind of the upstream part of the river. You've got downstream part of the river, right? So upstream is a little bit closer to where the mouth of the river would be, right? And downstream is, again, downstream. And I want to read a little story to you that is from a book called Preventionist Primary Strategies for Community Wellbeing. So here's that little vignette. While walking along the banks of a river, a passerby notices that someone in the water is drowning, and they help pull a person to shore. After pulling the person ashore, the rescuer notices that there's another person in the river in need of help. Before long, this person notices that the river is filled with drowning people, and more rescuers are required to assist that initial rescuer. Unfortunately, some people just can't be saved, and other victims fall back in the river even after they've been saved and pulled out of the water. At this time, one of the rescuers starts walking upstream. "Where are you going?" another rescuer asks. The upstream rescuer replies, "I'm going upstream to see why so many people keep falling into the river in the first place." As it turns out, there was a bridge that led across the water upstream, and that bridge collapsed, and people were falling into the water, into the river. The upstream rescuer realizes that fixing the bridge will prevent other people from ever falling into that river again in the very first place. So there is a quote that's by an American feminist, journalist, and social political activist, Lori Steinem. And she said, "We're standing on the bank of the river rescuing people who are drowning, but we have not gone to the head of the river to keep them from falling in. And that's our task in the 21st century." She wants us to, with this remark, she's using this analogy to basically say that we need primary prevention. We need to stop people from falling into that river in the first place by ensuring conditions so they won't fall into that river and put themselves in danger in the first place. More often than not, as public health practitioners, as health professionals in general, we focus on saving people downstream. We find people when they have high blood pressure and are at risk from complications from type 2 diabetes. And we really focus on providing medical treatment instead of trying to really focus on helping people to prevent conditions that throw them in the river in the first place. And this analogy, this story, this quote by Gloria Steinem is all about saying we need to go to the root of the problem. We need to go upstream and look at what's happening upstream. What conditions are causing people to fall into the river in the first place? And so instead of treating individuals one by one for adverse health events such as, disability and illness that's caused by the complications of disease. We really need to start focusing on what can we do to really fix that hole in the bridge? What can we do to focus on factors that later on cause disease and disability? And those would be such upstream factors as the social determinants of health, such as socioeconomic factors, as working on the social environment of an individual, or even changing the built environment around people to make it easier for them to live healthier lives. How do we do that? Well, we target social determinants of health by changing policy, by making changes in the physical environment, by making changes in the built environment. And so, therefore, really focusing on changing the context around an individual to make it easier for them to live a healthier life over the course of their lifespan, instead of waiting until it's too late. So that's what's meant by upstream and downstream factors. And as health professionals interested in the social determinants of health, we want to know what is upstream and what can we do to change upstream factors to help prevent and control adverse events that.
Okay, so I want to just dig into this a little bit from the nursing perspective. So when we talk about those levels of prevention, the different interventions that we might be involved with, these downstream interventions, those are interventions at the individual level, right? If we think about epidemiological triad, those are interventions to the host, right? Who's having the problem. So upstream interventions, these are big changes that affect multiple people. They're not just an intervention for one person. They're not saying, hey, you need to quit smoking, or hey, you need to eat healthier. These are changes that happen because of a change in policy or laws that are going to affect a whole community. So that is really key, because if you're looking at a question that's asking you about upstream and downstream interventions for a problem, we got to look at those interventions and think, well, which are the ones for individuals that's downstream and more costly, and which are the ones that are going to impact big groups of people. And so those would be upstream interventions. Okay. Lindsay, do you have any thoughts on that? Does that seem pretty clear?
Sorry, my brain is all over the place right now.
That's okay. Okay, so, well, we're just gonna leave it at that. So speaking of epidemiological triad, so there's a worksheet that you guys can look at and do on your own, just to reinforce what are the different pieces of this model. So this model is used to help us think about where we're going to focus our interventions related to a problem. Okay, so the host is typically in our nursing world a person who's either injured or ill, right? They're being affected by the problem. The agent is the problem that's affecting the host, whether it's an illness like a microbe or an accident, some kind of injury like a fall, something that's causing the problem. And then the environment is, where does this happen? Where does this interaction between these two people happen? So the sheet gives you it gives you a couple examples, right? So let's look at those first. So the first one is a situation where a pedestrian is killed by a motor vehicle on New Year's Eve while walking across the street. So if we wanted to try to prevent that from happening, and we wanted to look at issues related to the host, the person affected, then we could look at um, real specific things just for that person. Okay, that would still be prevention, like reflective clothing. We could teach them about crossing the road. We don't know anything about this pedestrian. We don't know if it was a kid and maybe they needed more supervision. We could do public education. That would be really high upstream, right? Because that would be like, public service announcement that we send out to the whole community. Hey, a holiday is coming up. Be careful, like Halloween, wear reflective clothing. Um, cross streets at the crosswalks. Don't just go running across the street. That kind of public education would be primary prevention, and it would be done at the upstream level. So then we have interventions that could affect the agent, what caused the problem, which is the motor vehicle. We don't know anything else about who was driving, what kind of motor vehicle, but they're saying, well, we could have interventions that affect the speed of the vehicle. So maybe if this is a residential area, we have bumps in the road, speed bumps, or we have slower speed limits. And then we can look at the lighting and how that could affect the vehicle. I know, like, I'm so used to leaving the lights in my car just on auto, right? On automatic. And we had gone to Florida and gotten a rental car. And I was driving at night, and the car next to me was like, "Hey, your lights aren't on." And I was like, "What do you mean my lights aren't on?" Well, they were, like they were set to be off, and I hadn't noticed it in the daytime. So, like, there are things that we can do within the agent of a vehicle. Now we even have those sensors, right, that can pick up if a car stops suddenly in front of you, it's going to apply your brake, right? So there are things that have been interventions here at the car, the agent, to help prevent this kind of problem. Then they've broken environment down into the physical environment and the social environment. So the physical environment are all those things like crosswalks and street lights and safer places for pedestrians to cross, like an overpass and signage. But then the social environment are things like, is there traffic enforcement? Like, are there police out during that time? What is the impact of alcohol sales policy? Or of course, here in Texas, we have blue laws that affect sale of alcohol on Sundays, but also we have drinking age limits, right? And then what about public transportation? Like, if public transportation is available, maybe people wouldn't be walking or driving when they're under the influence. So that's how we can think about this epidemiological triangle or triad, and break down the pieces of where we as nurses, if we're working in the community, can try to make an impact. Okay. So that is another one of the models that you want to be familiar with. Then the next one I want to show you this is another model, kind of more complicated version of epidemiological triad. This is called web of causation. And just like it sounds like, it looks more like a spider web. And this shows us many more variables involved in a disease or impacting a disease or a problem. Okay, so remember again that because we're talking community health and we're talking outside the hospital, it can be a disease, acute or chronic, but it can also be some other kind of problem impacting the community, like say drug overdoses. Okay, so that could be in the middle of your web of causation, and all the variables that connect and lead to that would be outside of that. So of course, this example is with diabetes type 2 diabetes, and it shows, many variables that connect in together. Let's just look at elevated blood glucose, because that's really, a very significant part of what we see with our type 2 diabetics. So there's many things that can cause that elevated blood glucose, right? Being on steroids, having another kind of a disease like Cushing syndrome they give. Stress elevates our blood glucose. Infection elevates our blood glucose. But look over here. Unhealthy diet affects our blood glucose. Insulin resistance affects it. So all these things are connected and together. And then when we go this way to stress, we start to see some of those social determinants of health really popping in too, right? When people are isolated, when they're living in unsafe places, when they're dealing with constant financial struggles, then those are all increasing their stress and can be elevating their blood glucose from that angle. But I would also like to venture that financial struggles, this is interesting that they've put expensive kosher diet in here. I wonder what the source was for this model, because that's not a common thing here in South Texas, but it is a thing, sure. But unhealthy diet is definitely connected with financial struggles, right? When people are living in a community that's like a community in poverty, then they are often also living in that food desert, right? Where there's not access to fresh and healthy foods. Instead, there's a lot of corner stores with just processed. Maybe you have canned things, but often you don't even have that. No fresh fruits or vegetables. Um, the other thing that we see in those, I'll speak for Corpus Christi, those areas of the community where we have the whole population is, when we look at our stats, are living in a lower income. There's a bunch of fast food restaurants. Now, these days, fast food seems pretty expensive. But it used to be, and still sometimes you can get, like I think at McDonald's, I have the McDonald's app, because with that I can get 99-cent coffee any day, right? But fast food kind of sells itself as you can buy a lot of food for a low amount of money. And it's super convenient. So for like families that are struggling, working multiple jobs, they don't have time to cook, they can pick up food and get something in everybody's stomach from fast food. So we can see, I really like this model because it tries to get to all the complications of that. Okay, so let's come back up here a little bit. And do we need to review immunity? How are you guys feeling about different types of immunity? This comes in because we're getting into communicable diseases and risk factors, and immunity is definitely part of that. I can give you like a quickie review. Okay. So immunity in general are all the ways that our bodies already are protecting ourselves from illness, right? This is not going to protect us from, falling off our bike. But when we look at illnesses, communicable diseases, immunity is a big factor. So we have two types of immunity. We have innate and we have adaptive or acquired. So innate immunity are all the ways that our bodies, just when they're healthy, have to protect ourselves from diseases in the environment. So we have all of the different kinds of cells that are part of our immune system in our bloodstream that respond in all the different ways you learned back in micro to attack, alert, spread the news and deal with that virus or bacteria that has infected the body. We also have a bunch of specific ways, physiological ways that our body protects itself, like intact skin, right? When we've got our skin intact, that protects us from a lot of stuff. Ciliary action within our lungs and our nose, all the whole respiratory system. We've got that low stomach pH that will often kill off bacteria or viruses that come into our stomach, which always makes me think about, so like when you've got something that you've picked up a bug from eating something off, man, that's a tough bug that lived through the stomach acids, right? But it did, and then it's causing the vomiting and diarrhea, which are, again, ways of our body to try to get that microbe out. So when we have patients who have issues in any of these areas that affect their innate immunity, that's going to increase their risk related to communicable diseases. Okay. So then over here in the acquired or adaptive immunity, we have active acquired immunity and passive acquired immunity. So I think of acquired means we had to go and get it. We got it and we made it ourselves. Or we got it either by making it ourselves, which is active, or it was given to us like a present, passive. So active means that our body was exposed to whatever was the infection, and we created antibodies. So the next time that we were exposed, then we have that immune response happens quickly, and we get over the illness much more quickly than if we didn't have any of those antibodies. Or we might not even really have the illness show up at all. Okay. So the natural way is that you had that cold your very own self. And you got that bad cold and you were sick for 5, 7, up to 10 days as viral illnesses. And your body fought it off and made those antibodies to that particular cold virus. And so the next time it comes around, you are able to fight it off much better. The other active way to address immunity is through vaccination. So just like hopefully you guys learn this, peds maybe, we have live virus vaccines, we have inactivated vaccines, and now we have the mRNA vaccinations. But no matter which way you get it, your body is being introduced to some aspect of the virus or bacteria. And so either a little piece of it or a little piece of the live virus. mRNA is a little piece of that messenger RNA gets into our body and creates that message and we respond to it. So we haven't actually been sick, but our body still mounts the same type of immune response. And then we have the antibodies. So sometimes with natural immunity, it can last for a really long time, like your whole life. Um, or it might wane with vaccination. It might wane. So we see that with folks who get COVID vaccinations, like the initial response is great, but then it wanes fairly quickly. That's why we get tetanus, diphtheria vaccinations every 10 years, because our immunity to tetanus wanes over time. But other things last longer. Um, and sometimes we say, well, if you get it naturally, whatever the thing is, then you have better immunity. I don't know if that's really true or not. But and then depending on the vaccine, you can have better or more or less coverage, right? So any given year, the flu vaccine that's been prepared by the scientists on their calculations of which strains of flu are circulating, we might only have like 60 or 70% coverage with that flu vaccine of what the viruses are that are actually moving around in the community. But still, it's boosted our immune response. It's kind of reminded our body, hey, don't forget about flu viruses and there's different strains. And so then if we're exposed to flu, we might get sick, but usually we'll be sick for much shorter amount of time. And I see this with my nursing students really clearly, right? Because they all get vaccinated for flu in the fall. But there have been a couple years that we've gotten another strain in the spring. And so then they're like dropping flu, 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 but they're only sick for maybe like 48 hours and then they feel fine again, right? It's almost like they've gotten that Tamiflu. That's what we see with Tamiflu, the antiviral is if they get it early enough, it shortens the length and severity of their illness a lot versus if you've seen, and you guys probably have, seen people sick with real flu without any vaccine on board, and they are really sick. And flu itself is very dangerous for our folks who have less innate immunity, right? Our little babies, our elders, folks that are smokers, folks who have are immunosuppressed and have diseases that affect this, so that they are super high risk for those sorts of illnesses that are around in the community. Okay, you can see I love this stuff. Yeah, that's my thing. I love vaccines. So then passive immunity, this is like immunity that's given to you like a present. It's passive. You didn't have to do anything and you just got those antibodies. So that can happen in two different ways. It can be maternal, which we also call vertical immunity, and think of it going from the mom high up to the baby low down. It can be either in utero or through breastfeeding. So you're just getting straight antibodies from mom there, and that is some good stuff. So that's why we see, very low ear infections, eye infections, all those respiratory kinds of infections in babies that are being breastfed. They also have fewer GI problems, and we can take advantage of this maternal or vertical transmission of immunity when we vaccinate mom while she's pregnant against flu or against COVID, or gets her Tdap booster. So she's gonna send those antibodies straight over to baby. And then the other passive immunity treatment is immunoglobulin. And this can be kind of non-specific, where, like, when I was in the Peace Corps, you guys, I know it's a million years ago, I don't know if they still do this, but they would bring us in like every 6 months, I think it was, and we just got an immunoglobulin shot in our rear. Like glue, this stuff is super thick, but just it was kind of a general boost to our immune system to help keep us healthy when we were, living in the tropics, and who knows what could happen. But we also have immunoglobulin that's specific to different diseases. So like during COVID, they were after people who had the illness and recovered, they were collecting plasma with immunoglobulin from them and using that to treat folks who were ill with the disease. And that just like gives them some direct protection, right? So they haven't had to do anything. They're just getting the protection from themselves. And then the last kind of immunity is that herd immunity, where we have people who are susceptible, right? The susceptible hosts, which is from chain of causation, right? The chain of infection, which we should pull up a visual on that. So they're susceptible, but all the people around them are protected from the disease, have immunity from the disease. And so because if you have enough people that are immune, then the disease is not going to travel within the population. So that is called herd immunity. So for example, with the measles outbreak that we had in the spring and summer in West Texas, for measles to have herd immunity, because it's such a bad boy of a virus, you have to have 95% of your population immune, okay, protected, to be able to protect anyone who's susceptible. So in this community where it really got started, there's some different factors, like they live out there in the boonies and, very rural area, hard to have access. And then they were also folks from a Mennonite community that were kind of just generally not accepting of Western healthcare and vaccinations. So what I remember reading was that the school vaccination rate, the MMR coverage level was in the low 80s in that community. So that is too many people who are susceptible. And so once it got going in there, it can spread so quickly. If you've ever seen anybody with measles, it's just like virus. Ugh. They're real, they have what's it called, like coryza or something. Their eyes are really watery. They have just runny nose, they're coughing, and they look terrible sick. But wherever they are, they're just spreading that virus around, in the waiting room, in the classroom, in the exam room, and people that follow them or are near them are very susceptible to getting that virus. So that's our little immunity review. We have this posted for you guys, and I'm going to wrap up quick here and see if you guys have any questions. The Texas notifiable conditions, remember that health legislation is mostly at the state level, right? So the state of Texas has their own list of notifiable conditions. which could be different from Louisiana, different from North Dakota, wherever, right? Some things will probably be pretty much the same, but we get to make our own list. This list includes communicable diseases, but also other sorts of problems, like here's pesticide poisoning, acute occupational, where's another one? Controlled substance overdose, okay? So this includes, and it gives you the guidance of how long you have to report that illness or problem to your local or regional health department using the number above, or you can use this website, which is the state website, to figure out where you're supposed to call it in. And so that's for, and they'd rather hear from multiple people. So they could be hearing from the lab, the doctor, the emergency room, so all the different places, everybody should really be reporting. So then the public health folks can then start to do their investigation if they need to. So, for example, let's look at some of the ones that are call immediately and think about that. So anthrax, botulism, yellow fever, hemorrhagic fever, tularemia. These are all diseases, smallpox, that show up on the bioweapons lists. Okay. And they're in the first category of the threat level of bioterrorism weapons because of their high mortality rate and how easily they can be spread. So it's not just a matter of, oh, we have this case of botulism and this person is really sick. It's that, oh, wait, this person has botulism. Where did they get it from? And we need to get on that really quickly because maybe it's a bioterrorism attack. Okay. So that is an important piece of information here. The other ones that I wanted to bring to your attention are coronavirus novel, and the same with influenza novel. That means it's a new strain, right? And we had coronaviruses before, right? But we had a new strain, that COVID-19. So if somebody picks up that there's a new strain, we need to know about it right away, okay? So this is kind of fun and interesting. Lead poisoning is on here of a child, any level, and adult blood, any level. So nobody should have any lead poisoning. Then there's all these footnotes, kind of interesting, if you are into that. Mode of transmission talks about the different parts of kind of, well, I just want to pull up chain of infection. I think it was in one of your PowerPoints. Chain of transmission, not chain of infection, chain of transmission. Yeah, I think I pulled up one of these for your PowerPoint. So this one is nice, from the Ottawa Public Health Department. And count on the Canadians to have some good resources. You can download this cute little PDF. So it talks about a chain of infection, which is another model that in this EPI module you want to be familiar with. So the agent, again, so that's similar to epidemiological triad, but this model adds in reservoir. Where is the agent hanging out? Where does it live? So like tetanus lives in the soil. E. coli lives in people, but you might find it in food or water. Wild animals, right? Like for our Lyme disease. Then it adds in portal of exit. How does the germ or the microbe go from the reservoir to getting out, right? How does it get out? So maybe it got exited out because somebody was sick, right? And they were vomiting and diarrhea, and that's how it got out. And then there was contact. How is it transmitted? So it was on the hands or the toys. Oh God, I just don't even want to think about this with like daycare places. So it got out from somebody, they touched something, and then that's the mode of transmission to get in the portal of entry. Oh, now the kid takes that teddy bear and, if they're a 1-year-old like my grandbaby, puts it straight in her mouth. Everything goes straight in the mouth. So that's the portal of entry. And then this person is only going to get sick if they're susceptible, right? So that is another thing about this model is it differentiates any host to susceptible host. Because maybe if I had immunity, I could get that germ into my body again, but maybe I'm not going to get sick and then spread the disease around. So that chain of infection or chain of transmission. And then here are your biological weapons classifications. Group A are your very most dangerous, immediate response ones. Group B, less, right? So these group A ones you want to be familiar with. You guys, there's always an anthrax question on people's NCLEX. Like, I don't know why, but that shows up. So have those to review. You have a couple more videos you can watch if you want to. And then there's one other worksheet. This risk factors worksheet in all your free time, or you guys could maybe work on it together. We put this together based on these health problems that pop up on end of nursing school exams, okay? Whether it's a community exam or an exit type, the ones that you guys are doing in ATI. But these are common problems that show up. But from the community health point of view, we want you to think about what are the risk factors for that problem? What kind of screening do we use, secondary prevention, to identify that problem? And then what are some interventions by level of prevention? So you can work through this, but I just want to touch on two things real quick right here. So breast cancer, what do you think is the biggest risk factor for breast cancer besides gender?
Genetics.
Nope. Biggest risk factor. Smoking? No.
Oh,
So between the genders, who has it more commonly? Women. But it's age. Okay, so this is a great example of you guys have been in school. Well, you guys have really been in school, but you're at the end of your program. You know a lot of stuff. You know fancy things like genetic screening for breast cancer. But the most common risk factors are just gender and age, right? Now, that doesn't mean that young women don't ever get it. But when we look at the population, older women is much more common, okay? Then with congestive heart failure for heart disease, there was a question that popped up. Now, it was from Evolve, so I don't know if you guys will see this ever again, but I was like, oh, I don't know that. So there's a screening lab test for CHF. Do you guys know what it is? April's nodding her head.
Talking about the BNP?
Exactly. Yeah. So that showed up on a end of course community exam, right? Because again, like they're thinking you guys have had all your other courses, all your education, but now you're looking at these problems from the community lens. So that one, I think a lot of this other stuff, I mean, just kind of review it on your own just to feel comfortable with that. This unintentional injuries in kids, this gets nursing students. They want to make kids have like complicated diseases, but those things are relatively rare, right? The things that kids die from are typically preventable injuries, unintentional injuries. So this is where we see things like drowning and falls and not wearing seat belts, those real basic safety things that we want families to do with their kids. That's going to help keep them safe. And then we added this little note down here about these two diets that often, again, kind of show up on these exams. Mediterranean diet. What does that generally mean? Things that we should eat.
We just did it. It was like nuts and olives and like the chickpeas and
Yeah,
almost like vegetarian.
it is almost vegetarian, but then with fish, very even small amounts of white meat, hardly any red meat, and that we know that Mediterranean diet, there's lots of research to support. What do we use it for? Which problem?
With those two things?
Yeah, well, with Mediterranean diet, which one? That one for?
The
Most
Kidney,
for
Digestion.
renal.
heart disease. Heart disease. It's just it's a big one for people who have heart disease. And then DASH is for what problem?
Same.
So
Hypertension specifically, right? That's the low sodium one to watch your salt with. Okay, questions. I know that's well, this ended up kind of being like class today.
I like totally forgot. We had an exam at 8 a.m. and like
Oh,
last
you
night was just like a shit show. Like I had my kids at baseball, like my son that has autism had this huge meltdown, and so I had to like pull him away into the car. I was mortified. All the coaches are like, "No, mom, you're doing good." I'm like, then I
Oh,
went
this
to
was
go,
last night or
yeah,
this
and
morning? Okay, last
then
night.
I went to pick up Little Caesars just because I was done,
Right.
and I
Yeah.
had ordered ahead for 7:45. I sat there for an hour. An hour. So I didn't get my kids home till 8:40. Well, I didn't get them home till like 9. Still had to feed them, have them take baths, like homework. Just so I'm exhausted. And I have to drive there today.
Oh gosh.
And so I just forgot. And then I looked up and was like, oh my gosh, Zoom.
So what test did you guys have this morning?
Transitions, the exam one.
Okay. All right. Well, I'm sorry. I get it. I hear you.
What?
It is October 1st, so we can really be counting down. It's not even 3 full months and you will be done with nursing school.
Yeah.
It's less than being pregnant.
I don't have a uterus, so that's not even there's 73 days. There's 73 days left.
73 days. All right. Yeah. So just take it one step at a time. I wouldn't, you guys are doing well on these quizzes. So just keep powering through.
I know April gets it. It's just like the whole element added in of traveling back and forth, just like cuts away from your study time and it's just exhausting. It's really a lot.
It is a lot.
But like you said, it's almost done. So
It's almost done. And maybe I don't know if it would work, but can you like listen to the little PowerPoints that I posted while you're driving?
Oh, yeah, that's usually, well, I think you posted them both ways with PowerPoint and with like Zoom, like, because if they're on PowerPoint individual slides, then I can't get that to play on the phone. But when it's like lecture format, like a Zoom and somebody's going through it, then it'll play.
Ooh, well, I can pull those and add those.
Okay,
Okay.
thank
'Cause
you.
I think it makes it like an MP4 or something.
Yeah, yeah, that works.
I will add those so I can be on the drive with you, just what you wanted.
I listened to the therapeutic communications ones when I was driving back and forth.
Wow. Oh my gosh. And what are you doing down here this week?
We have the third day of Sims for transition, and then Friday we have the Friday night in the ER thing.
Okay,
So
good. You're making progress, one step at a time.
yeah, I didn't get to do anything last week during transitions sim, so I already know they're like, oh, we're gonna give her the coding patient. That's cool.
April, do you have any questions? No? Okay.
Oh, good.
Wow.
I
will-
miss you. It's time to start our community stuff.
Oh, that'll be
No.
fun. That'll be good.
We'll be together soon.
Yeah.
Okay. You guys take care.
All right.
Drive carefully. Be kind to yourself. Okay.
I will.
Okay. Good. Okay.
All right. Bye.
Bye.